Hello. Boo.
So, we are ready to start. To je to, dobře. So, good afternoon. I would like to start nearly the last session, but it's not the last one, but we have to take the time because other sessions are after us and we have to finish today. Yes, this is the Saturday already. So welcome now, and this plenary session is about the shifting of the borders in the science and legislation. So I would like to ask the first speaker, and this is Dr. Hazekamp from Netherlands, and he will give us this lecture now. Yes.
Okie dokie.
Or you can use this microphone there.
Yeah, if you allow me, I like to walk around a little bit because I'm going to point things out on the screen. So if some people here are angry with me, then I understand, because yesterday I was on the program to be the chair of the neurology discussion, but I think there was a mistake in the book. So people were looking for me, like, Arno, where are you? But I changed with somebody else. So I'm not an expert in neurology and cannabinoids, but I hope that I know something about this. Where's the remote control? Oh, okay. That works too. So this discussion is not about what do patients want, because I'm not going to give you the answer. It's a question. Do we know what patients want? Because I'm a scientist and I would like to know as much as you, but it doesn't mean necessarily that I can give you the answer. I showed this slide yesterday, 2 days ago, also in my presentation, that cannabis is a medicine in some sense because there's active ingredients. We know that it works for a whole bunch of people. The chemistry is known to a certain extent, and there's even some clinical trials done. But there's a whole bunch of other things that are not so clear yet. We haven't made up our mind yet. We're trying all kinds of things. Sometimes they work, sometimes they don't. Administration form, dosing, how much am I supposed to use? When is it too much? And what about all these varieties? So I said that it's not so strange that a lot of people, when they hear about medicinal cannabis use, they think about this picture in their animal brain. They think like, yeah, right, medicinal cannabis, smoking, is that a real thing? So what we're trying to do in this conference and in general over the last few years and in the coming years is we're trying to bring together modern medicine as we know it, simple pills that you swallow once or twice a day, with something really strange that started out a little bit like this. Joints rolled into into a container, and then you put a sticker on it, and then it's suddenly a medicine. If you try to bring those two things together, you get a strange kind of beast, right? So in the past, people thought that this really existed, and they were afraid of it. But because they studied it, and they asked questions, and they start to go into the woods and, poke with sticks around, they found out that this is not really the scary creature that they thought it would be. And we're kind of doing the same thing with cannabis. We're trying to bring two things together to very different cultures, to very different angles, and we don't know yet what it's going to look like. Well, some obvious needs of patients, I think, first and foremost is a legal system. Well, we're here in Czech Republic because they have created a legal framework to do this, but the other things, it's not so clear yet. What is quality? Should we care about it? How much is it allowed to cost? What about composition? How many varieties should we offer? Is that important? How much dose do we need? And the administration forms. And in this presentation, I'm going through some of the information we do have available, or the questions we can ask, to try to answer those questions. And one of my major tools is this study that I've done together with a whole bunch of people from the IACM, the International Association for Cannabinoid Medicine, and we just simply asked questions among patients. So almost 1,000 patients from 31 countries. This was an online survey, and it lasted for 6 months, and it's the largest international survey that's been done under patients. Well, on average, these are patients that know what they're talking about because they are using it now at the time of the survey. They have experience with at least 3 or 4 different cannabinoid-based medicines, so not just smoking or vaporizing, but also marinol, nebolone, and other kinds of compounds that contain cannabinoids. Usually, this is the statistical data came out of the survey, the the health professional was involved in the management of their disease, and they've been using it for several years. So these are basically the experts. It doesn't get any better than this. So what do they say? We asked them, what kind of disease are you using cannabis for? So basically, what label is your doctor putting on you as a patient? Are you an MS patient? Are you an AIDS patient? Are you a cancer patient? Then the answers are all over the spectrum. There's no clear pattern what people use cannabis for. If you ask them what symptom are you using cannabis for, so it doesn't matter what it's called, but what is the problem you're trying to address, and you see that 75% almost of the answers are just the top 5. There were 47 options, and all of them were quite reasonable. There were no very rare symptoms present, but this is the top 5, very, very clear. So maybe it's not that diverse as we sometimes tend to think. We asked them also, what is the amount of cannabis that you... No, sorry, this is about preference. We asked them if you could have only one choice of administration form for the rest of your life. Which one would it be? We asked them about herbal cannabis, but we also compared it to the pharmaceutical preparations. So this is kind of covering everything there's on the market right now. And it's very clear that the highest numbers, together with nabiximols, which is Sativex, but it was only 7 responses, the highest preference was for smoking and vaporizer, so the inhaled route of administration. You can go further into detail and ask them, okay, what do you like about it? What do you not like about it? And can you just give it a number? Like in school, right? How well is it doing? For, how much do I need in the day? How easy is it to find a dose? Does it irritate my lungs? So then the highest numbers are here marked in the table. You can again see smoking and vaporizer are the best of their class. The highest ranks. And you can combine those two things, and within the top 5, which cover 75% of the answers, here they are. You can ask them, well, per category, what do you prefer? And you see there's virtually no difference based on the symptom you're trying to address. Smoking and vaporizer are on top, food and tincture, and then a little bit of the rest. The only thing I have to say is this does not yet cover the oils, cannabis oils, because at that time there was not much talk about oil yet. This is 2009, 2010, and I'm sure this picture will change, but this is just to show you that these kind of questions can be asked and they give you information. What do people see as problems to address with the administration forms that are present today? Well, mostly bad taste. Cannabis tastes like green stuff. Cannabis tea, for example, is horrible to drink. Smoking is not the best thing that you can imagine in the world. Drowsiness, obviously. Uncontrollable appetite. That's nice when you don't have an appetite, you get one, but if you already have one, you don't need more. Although maybe it's a good idea when you want to clean out your fridge. And getting high. And that's an interesting one because a lot of opponents of medicinal cannabis will say, you just want to get high. There goes Arnold. You want to get high, and this medical use is actually not a real medical use, but getting high is actually not so preferred by real patients. The other source of information is the SFK study. I published this a few years ago with a colleague from the University of Utrecht in Holland. And it's basically based on, it's not a survey. This is based on a Dutch foundation that collects almost every prescription in the Netherlands. When you go to the pharmacy, then they will take that information and put it in a database. And it covers about 92% of all prescriptions that are delivered to patients, but it's all anonymized, so they don't know who you are. But it's an almost complete overview. There's no selection. Everybody's there. We were able to catch 5,500 prescriptions until 2010. We're now making a new study up till 2014, so I can tell you in hopefully a few weeks. And the main conclusion, what do you think is the main conclusion that the Dutch government, at least the Dutch Office of Medicinal Cannabis, found very, very significant? I give a picture here so to help you guess. Huh? No. Conclusion is no tolerance or dose escalation over 8 years of use. People don't go crazy on this stuff. They use it, they start, at some point maybe they stop, but they don't have to use more and more and more. And this was the biggest fear of governments in the beginning. Like, once we start this, where's it going to end? Is everybody going to end up addicted? According to those numbers, no. If you compare those numbers, you can see that the Dutch statistics have a slightly older population and less men. And this is a very interesting number. This 0.7 got me in a lot of trouble with a lot of people. I wanted to discuss about it, so more in a second. But it's important to realize that statistics are always somehow biased, right? If you look at the age distribution, the IACM survey has a lot more younger people. The SFK, which is a complete overview of what's happening in the Netherlands, is more going towards the older population. And of course, they have different preferences and different ideas. But you can measure this and you can compensate for it. So what's a normal dosing regimen? If you ask in the IACM survey, it's all about 3 grams per day. But the Dutch study indicates 0.7 grams. Isn't that weird? So here's 0.7 and 3. That's a pretty big difference, right? And some people told me, no, Arno, you got it all wrong. We use 3 grams in another place, in another country. But are we addressing these questions? Because 0.7 gram of 20% THC cannabis equals 1.4 gram of 10% cannabis. And if you would vaporize that material and compare it to smoking, vaporizing, if you vaporize your cannabis, it doesn't burn. You can use it again. If you use it 2 times, it's 2 times more efficient than smoking it, because then you end up with ash. You cannot do anything with the ash. So in just 2 steps, you go from 0.7 to close to 3. And this, I think, is a very important question. We don't consume grams. We consume cannabinoids. And they're contained in this gram. But how much is it and how do you use it? With these kind of numbers, we can go into details of how much does it cost to treat people. Well, these costs are just simply based on how much do you get and how much do you pay for it. But now with these statistical numbers, we can start to see how much does it cost per day. And if somebody doesn't agree with these numbers, fine, we can change them right now. You know, and we'll recalculate. But the thing is, you can calculate these things. And is that important? Yes, because health insurance companies also went through the crisis, right? So money has become important, and they were always asking for clinical proof. Can you prove to us that it works? And then we'll think about it. And then the crisis came and they said, well, you know what? Healthcare is expensive. Isn't cannabis cheaper than the pharmaceuticals that we're giving these people? For the people, you know, that's, the price is an issue, but for the health insurance company too. And the medication that they usually get is extremely expensive. Hopefully they don't get to see the bill, but it's there. So when we tried in 2009 and 2012, you know, what is the position of health insurance companies, we see that it actually improves reimbursement from basic insurance, so you don't have to have a fancy extra insurance, and they are a little bit more strict on indications because they start to see like, oh, maybe it's going too fast, you know, we want to be a little bit careful, but they even start to pay for vaporizers, so they understand that cannabis is not finished. You know, you have to consume it in some way, and you can help patients with that. Quality control is another issue that I mentioned in the beginning of my presentation, and this is the things that cannabis is being studied for or tested for in the Dutch program. And is that important? Yes, because I spent some time also in the US, and I started to see that labs were all doing their own thing. I have to say this is 2010, so I don't know what the status is right now, but I'm not the one that can say this is a good lab, it's a bad lab. I'm not sure if anybody can, but what I can do is make one set of samples, liquid samples, so no plant material. You don't have to extract anything, you can just put it straight in your lab, and these are the results that I get from 10 different labs. That's kind of all over the place. And this is a method, it's called a ring test, and this can be applied in any situation to just compare what's going on out there. If everybody's different, then there's one conclusion. Some people are wrong, so figure it out. Varieties. I think many people have seen these beautiful sativa indica schedules, and they look beautiful, and they may help you personally, but scientifically, this is very wild. Where does it come from? How do you know? Is this table similar or different than another supplier of varieties? And this is no science. What we can do is take a whole bunch of samples, in my case more than 330 samples. We can test them for chemical composition. Right now we're at 47 different compounds that we can identify and quantify, so we know the amount. We can look at genetic differences, and we can combine it with the information we get from growers and patients. You know, is this a sativa, is this an indica? And then as a scientist, applying some statistics, you can simply find something like this. And it doesn't mean much to you, but what's happening here is that I'm visualizing the differences between all these varieties, and it's basically like a world map. If I know the location on a map and I know the distance to another point, I can start making a map. So yes, there's 200 countries in the world, and nobody can remember them all, I think, but they're organized in just 6 continents. That helps when you travel, right? So 1,000 varieties, who knows, 700, I don't care. Are we able to cluster them in a number of main groups and say, if you are problems with sleeping, then you go to Asia. And when you have pain, you go to Europe, right? This is kind of an idea of thinking. This is possible. And this is what Bedrican has developed this method on. I always call this a Starbucks menu. So do you want 1 shot for 2 shots? Do you want to have some CBD in it? And do you want to have the sativa or the indica varieties? And this is not complete, I know, but it gives us a map, a way, a road to keep thinking. And this can be followed, this can be added to by patients. New information can be absorbed. Almost getting to the end. This is an important one because are the number of people that you treat really an indication of success of a program? Well, there's huge differences. This is a number that I got from the IACM website. The numbers may be not totally correct, but the idea is clear that in Netherlands we're serving only a few people per 100,000 people. That's called prevalence. In Canada, Israel, US, it's increasingly going up quite fast. And the question is Holland underrepresented? Because we have the coffee shops. If you don't want to go to your doctor, you just go around the corner and you go to your cannabis place. Maybe there's good access to healthcare, so you can use other medications first because our healthcare system pays for a lot of stuff. And if you have to pay for it yourself, you may go to cannabis. Is the US overrepresented? Because there's still severe risk of being in legal trouble when you're not a medical patient. So are people trying to become a patient even while they're not? I don't know. But this is a Dutch situation where we have decided that the medical program is very, very separate from recreational use. Very strict doctors, a good selection of patients. But that means that there may be a number of unrecognized patients that now are forced into the recreational system, which is not that much of a problem because it's not illegal. And you can go to a coffee shop. It's not simple for everybody, but this is a simplified version of what I'm trying to say. In the US, people say, no, everybody should be treated as a patient if he feels like a patient. So we will accept that part of the people in the program may not be real patient. I don't like to use that word real. That's why I put it in brackets. But it's kind of a question, it's an uncomfortable question that nobody really would like to ask. But it's there. So when you're talking about physicians, which I think are the gatekeepers of the system, they should be the ones that decide, are we going to put this patient in the system or not? They have to know a lot, about varieties. That's complex stuff that usually they don't have to memorize. Administration forms, dosing regimens, but they also have to ask hard questions, a screening. If they want to make the system succeed, they should want to go in this direction. So what do patients want? I think it's pretty clear from the fact that we're here today that plant-based products are important, a proper choice of varieties. I say proper, not 1,000, not 2, but a range, but a smart range, clear labeling, what's in my medicine. You're allowed to know what's in it. Reliable quality control and health administration. And I think that will help us if we can address those things, and I think we can, and we're already doing it. We can educate physicians with information that is science-based and makes sense to them and also respects the opinion of patients. We can reduce stigma in society and hopefully go for reimbursement. So, and I think that we should focus more on patient-inspired research, where patients and researchers join forces to answer questions.
Thank you very much. Our discussion will be at the end of all 3 presentations because last presentation was already done on Wednesday. So we have only 3 presentations now. I would like to ask Professor Sanchéz from Complutense University Madrid, Spain, about their lecture, which will concern many things. The endocannabinoids, phytocannabinoids, and cancer. Please.
Thank you very much. Ahoy. I would like to start by thanking the organizers for inviting me to participate in this event and for giving me the opportunity to discover this beautiful city. I'm going to try to summarize the work our group has been doing for the last 15 years on cannabinoids and cancer. As you all probably know, cancer is a disease that is produced by the uncontrolled proliferation of certain cells in the body that have acquired mutations. And this process is usually accompanied by the formation Okay. Is this better? No? Closer? Okay. Sorry. Is that okay? Okay. I'm sorry. So I was explaining what cancer is, and I was in this step here of the disease, a process called angiogenesis, which is the formation of new blood vessels that supply food to the growing tumoral masses. And in the most aggressive cases of cancer, the process has an additional step, which is the formation of new tumoral masses at distant sites, what we call metastasis. So if this is not bad enough for patients, in some cases they also have to deal with pain associated to their disease, and also with the side effects of current anti-cancer therapies, which include lack of appetite, nausea, vomiting, toxicity in very important organs, and many more. So it has been known for decades that cancer patients can benefit from cannabis, from cannabinoids, because these compounds stimulate appetite, they decrease nausea and vomiting, and they also have analgesic properties. But what our group is trying to demonstrate is that these compounds can also be used to block tumor progression itself. In other words, that these compounds can be used as anti-tumoral agents. So we started this work by 15 years ago, and we decided to focus on a very aggressive type of brain tumor, which is glioblastoma multiforme. These patients are currently treated with surgery plus radiotherapy plus chemotherapy. And despite this very aggressive approach, the life expectancy of these patients is roughly 1 year. So we started our research by doing very basic cell viability assays. And I just show you here a very simple example. On your left-hand side, you have human glioblastoma cells that are growing in a tissue culture plate, in a plastic plate. And this is how they look when they are happy and healthy. And this is how they look when they are treated with THC. And as you can see, there are fewer cells, and they are not attached to the plastic, and these are all signs of cell death. So we, of course, tried to determine if this effect was also produced in vivo. And along these years, we have used many different animal models of cancer, and we have always observed the same thing, which is exemplified here in these two experiments. On your left-hand side, you have immune-deficient mice in which we have induced subcutaneous tumors, human brain tumors. And this is what happens when we treat the animals with THC. As you can see, comparing these images with these images, the tumors grow slower than in those animals that have not received THC treatment. And this happens not only in immune-deficient mice, but also in immune-competent animals. And here you have rats, and in this case we induced the tumors inside the brain. And you can see in the left one rat before receiving THC treatment. This white mass here is the tumor in these two different projections. And this is the same rat, the very same rat, after THC treatment. And you can see basically no sign of the tumor. We have been very interested in understanding in molecular terms what is going on inside the cell to end up dying. And after 10 years of work, we know that cannabinoids, by binding and activating CB1 and CB2 receptors, induce a cellular response that is called endothelial reticulum stress, which produces the increase of this molecule here, which is a lipid that induces the death of cancer cells. This pro-apoptotic lipid, ceramide, produces the increase in the levels of a number of proteins inside the cells. I'm not going to bother you with the names, But the take-home message is that all this information, all this signaling, intracellular signaling, converts in the inactivation of the master regulator of cell survival. And by doing this, the cell activates a program, a self-digestion program, and a suicide program that is called apoptosis. This work that I have shown you in the last slide was coordinated by my colleague and friend Guillermo Velasco, and they have more recently analyzed, thinking about potential clinical trials with patients, what is the effect of combining current treatments for glioblastoma patients with cannabinoids. And as you can see here, when we treated these animals with either THC alone or with temozolomide alone, which is the standard therapy for this kind of patients, we observed a nice reduction in tumor growth comparing with those animals that received no treatment. But when we combined both drugs, as you can see here, the delay in tumor growth was remarkable. But we have not only worked with brain tumors, we have also studied the effect of cannabinoids on breast cancer. And in this case, we have focused on a specific subtype that is characterized by the overexpression by high amounts of this protein here, HER2. These patients are currently treated with a monoclonal antibody against this protein. But despite the big success that this compound has meant in the clinics, only 1/3 of the HER2 positive patients respond to this therapy. And among the responders, most of them end up developing metastasis. So we think that these patients still need an additional treatment for their cancer. To use the effect or to analyze the effect of these compounds, cannabinoids, on this subtype of breast cancer, we decided to use this animal model, which is called MMTV-NEU. And these animals have been genetically manipulated to overexpress the oncogene NEU, which is the rat equivalent of HER2, under the expression of this promoter. And as a consequence of this manipulation, these animals develop tumors, and they do it in a spontaneous manner. And they do it after very long latency periods, as you can see here, and roughly 70% of them develop lung metastasis. And for all these reasons, this animal model is considered a clinically relevant model of HER2-positive metastatic breast cancer. So what we did with these animals was to treat them peritumorally with THC for 3 months. And we started the treatment as soon as we detected the tumor. And what we observed is summarized here. First, THC reduced tumor growth. This is the behavior of the tumors in the animals that have not received THC treatment. And as you can see, the tumors grow exponentially. But when we treat the animals with THC, the tumor growth is dramatically decreased. But THC not only reduces tumor growth, it also reduces tumor generation. As you probably know, mice and rats have more than 2 breasts. In fact, they have 10. And each one of them is susceptible to generate a tumor. So what we did was to analyze how many tumors were developed per animal. And as you can see in this table here, in the control group, the group that received no THC treatment, we found 40% of the animals with 4 or more tumors in their breasts. But in the THC population, 50% of the animals presented just 1 tumor, and we didn't find a single one with 4 or more. So THC was not only reducing tumor growth, but also tumor generation. And THC also reduced, there's a panel missing here, but you have to trust me. THC also reduced the percentage of animals with lung metastasis. The numbers were around 70% in the control group and around 20% in the THC group. But these results were obtained with mice, as I told you before. What happens with human breast cancer cells? Are they sensitive to cannabinoids as well? Well, the answer seems to be yes, and I'm going to show you a couple of experiments. Here we cultivated the human breast cancer cells in the same plastic plates I was mentioning before, and we challenged the cells with different cannabinoids. I want you to focus on the green bars for the moment. And as you can see in those bars, THC decreased in a dose-dependent manner the viability of these breast cancer cells. Interestingly, we observed the very same thing when we treated the cells with CBD, with cannabidiol. And I have to look at the yellow bars. As we increased the concentration of CBD in our cultures, we decreased the viability of the cells. And we also tested 1-1 combinations of THC and CBD, trying to mimic Sativex. And as you can see, we had an even better effect on decreasing the proliferation of these cells. We then moved to an in vivo paradigm. And in this case, we generated subcutaneous tumors in immune-deficient mice, and these tumors were originated by injection of human cells, human HER2-positive breast cancer cells. And we treated these animals either with THC alone, CBD alone, or a 1-1 combination. And what we observed was, first, that THC produced a nice reduction in tumor growth, that CBD, and this was very good news for us, produced basically the same effect, and that the combination, the Sativex-like combination of THC and CBD, produced, like it did in vitro, a more dramatic effect. We know in very good detail what is going on inside the cell, inside the cells, why we have these antitumoral responses. And we know, for instance, that THC is reducing cancer cell proliferation. Here we stain in pink cells undergoing proliferation. And as you can see in this example, and this is a slice of a THC-treated tumor. Here there are less pink dots, which means that there are less cells undergoing proliferation. THC also stimulates this suicide program that I mentioned before, apoptosis, and you can see that here by counting the number of cells that are stained in pink. And THC also reduced that process that I mentioned in the first slide that is called angiogenesis, which is the process that supplies food to the growing tumoral masses. So THC is also blocking that process. And we also find out something that we think is very important, and is that, at least in breast cancer, the effect of cannabinoids is mainly mediated by the CB2 receptor and not by the CB1 receptor. And I show you here just a couple of proofs of what I'm saying. These were the genetically manipulated animals, the ones that spontaneously develop breast tumors. And we can reproduce the effect of THC with a CB2 selective agonist. And in this example here, in this case, we were generating breast tumors by subcutaneous injection of breast cancer cells. And we observed that the reduction in tumor growth that we obtained with THC was blocked when we used a CB2 selective antagonist. So these and other proofs that I'm not showing you are telling us that, at least in breast cancer, the antitumoral effects of cannabinoids are produced by activation of the non-psychotropic CB2 receptor. But again, these results were obtained in animal models of cancer. Do we have CB2 receptors in human tissue? Well, to answer this question, we analyzed the expression of this protein, the CB2 receptor, in a series of 700 human samples. And we scored CB2 expression from 0, no expression at all, to 3 high levels of expression. And we found, I mean, don't waste your time looking at the numbers. I will guide you through the important stuff. What we found was a very strong correlation between the expression of CB2 and HER2 positive tumors. That means that basically 100% of the HER2 positive human tumors express CB2 receptors. It's not 100%, it's 97%, which is basically all of them. If you add all these numbers, you will have 97%. So we have a lot of preclinical information showing that cannabinoids work as antitumoral agents in animal models of cancer. What do we do next? So we think it's time to do clinical trials. If we want to know if cannabinoids work in human patients, we have to test cannabinoids in human patients. As far as I know, there are 2 ongoing clinical trials in the world right now. One in the UK, promoted by GW, with glioblastoma patients, in which they are trying to analyze the effect of a combination of the Sativex plus temozolomide in these kind of patients. The second trial is being performed in Israel with CBD in patients with solid tumors, and the primary endpoint is to analyze the overall response rate. These are the only trials that are ongoing as far as I know and according to this website. Just to summarize, I hope I have convinced you that we have strong evidence showing that cannabinoids work as antitumoral agents, at least in the preclinical models we use. You know that they are safe, and we know it from our preclinical studies. We know that all the effects I have described are not produced in non-transformed cells, in non-cancerous cells. They are also safe because in breast cancer, the effects of cannabinoids are mediated by the CB2 receptors and not by the CB1 receptor. Most of these effects are reproduced by CBD, which is also good news. And we also know that these compounds are safe because there have been many, many clinical trials showing that. We also know that cannabinoids have targets in human patients. Remember the strong correlation we have found between HER2 and CB2. And I didn't show you any slide, but we know that there is basically no expression of CB2 in healthy tissue, which is also good news. And of course, cannabinoids have additional advantages that make them very interesting for the cancer patient population. They are analgesic or exogenic, antiemetic, and so on. So as I was saying before, what do we do next? We, basic researchers, will of course keep on doing research, basic research, trying to find out more about the mechanism of action, if these compounds combine well with other chemotherapeutic agents. And we will do that because that's what we do for a living. But I think it's time for other people, and I'm talking about doctors, and I'm talking about politicians, and I'm talking about legislators, to move on and potentiate and promote more clinical trials. I want to finish by acknowledging all the people that have been involved in this project during the last year, and very especially to this person here. You probably know him, Manuel Guzman. He's the person in charge of everything I said. And the small group I lead with Edu Pérez Gómez, Clara Andradas, Sandra Blasco Benito, and Rodri Hernando. And thank you very much for your attention.
Thank you very much, Professor Cristina Sanchéz, for your interesting basic data from experimental and also the clinical work. The next theme will be also the cancer pain, and it will be done by Professor David Meiri from University of Haifa from Israel, and it's anti-cancer treatment. Anti-cancer treatment, okay. So, and cannabis, yes.
Okay, so two things to correct. First, I'm associate professor, and second, I'm not from Haifa University, I'm from the Technion, which is in Haifa, but it's a different...
I don't
okay,
know
so it's okay. I'm happy that I'm speaking after Cristina, and I'm sad. First, because after hearing 3 days of lectures here, I changed totally my talk, and I threw out most of this, the accurate science, because I think it's not fit to the audience. But after Cristina speaking, I'm feeling naked without my science behind. Second, most of my talk will show that there is no much knowledge. And again, speaking after her, it's a little problem because the knowledge that we know about cancer is coming from the Spanish group, I will call it, which is now quite pioneer in this field, or there is not much more than they are doing. How I'm changing it? The white one? Okay. So, I'm very green in this field of cannabis. My lab is Laboratory of Cancer Biology Research. I'm doing cancer biology and cancer research. And basically I'm research a protein that it's part of the cytoskeleton of the cell. You can see here 2 cells standing one behind the other, and you can see actin, and that's what I'm doing. It doesn't matter for you anything, and we are growing the cells in plate like Cristina just told, and you can see a cell here, and this is the nucleus, and this is the knockout mice that you see the cells are different. It really doesn't matter whatever, and we draw a whole bunch of pathways around it, and we find it through GPCR receptors, which are like CB1 and CB2, but for different, totally different aspects. And we showed about this protein that if you knock it down, you eliminate it, you are losing, like you eliminate now the tumors. You can see here on the right here that there is no tumors, and in the green there is. And again, it doesn't matter at all to what I want to speak now. But this is my little brother, my younger brother. In Hebrew we call it little, but he's not little at all. When I was younger, as a kid, I always brought him and said, "This is my little brother, I have another 2 bigger ones." So my younger brother had a Crohn's disease. And 1.5 years ago, he got a very severe attack, and he was in the hospital for 2 months, and they tried to treat him all over the kinds of things that we know how to treat Crohn, and nothing helps. And when they sent him home, they gave him cannabis as a treatment, mostly for the pains. And he is a guy that even he looks like that, he didn't smoke in his life, and he's a really nice guy. And he called me, and he told me, "Daddy, they gave me cannabis as a treatment. Are they crazy? What do you think about it? I'm the doctor in the house, right? So what do you think about it?" And I told him, "First try and see if it's helping. I don't know much, but let me read." And I started to read about it, and I was quite shocked to see the people that don't know, for medical doctors and for scientists, there is a site called Pubmed. So you can see all the papers, scientific papers that related to the field. And so I wrote Crohn and cannabis, and there is 6 papers on Crohn and cannabis. 3 of them showing it's really helping for the inflammation, whatever. One of them showed that it makes the opposite, it makes it more severe, and 2 are reviews for the other 4 papers. So there is not much knowledge about it, and I was shocked why we are giving somebody a medicine without really science. And I started to read more and more about about cannabis, and I find, so doesn't matter, I will skip this one. So I find that it's very ancient treatment, and until 1937, 20% of all the prescription had cannabis, and it sounded to me very serious. And I started to read more and looked for more papers, and I saw that there is effect in many effects. I can't read what is written there, but inflammation and I need to go closer. And it's for psoriasis and killing and slower bacteria growth and fungal. But what is catch my eyes, that it's also eliminate tumors and by apoptosis and cell death, as Cristina just showed, right? And when I wrote cancer and cannabis, I got over than 1,000 papers, and I was very surprised about it. And I started to read these papers more and more because what I'm doing is cancer biology. And first I was very surprised to see that they are very, very shallow. In our world of scientists, we are looking for really established works, and most of these papers are anecdotal. Most of these papers are case study. Very few of them, and again, most of them coming from that group, are really doing science that I'm, as a scientist, believe in the results. Because if somebody is telling me about an old guy that was almost blind and now we smoke 2 puffs of cannabis and he's standing and running, fine. I have a friend that go to the desert for 2 weeks and cure himself from cancer, and we all can open the US TV and see people that putting hands on blind people and they're waking. Okay, this is not science and this is not medicine. For me, science is something that we can repeat, we can see, we have control for it, and there is really, really few papers that showing regarding cancer, and I'm not talking about pain, I'm talking about that you're giving and it's really fighting the cancer. Okay, there is really few papers that showing real data. So I went deeper and I looked, and there are papers that really showing that it's helping to glioblastoma, as we just showed, just saw skin carcinoma, breast cancer, and few others. And this is catch me. And what was very, I was very happy to see that there is 25 papers that showing that cannabinoids can stop the cells to migrate and invade, to be more aggressive through the protein that I'm working on, through RAW-A, which is my baby in the lab. So I was very happy, and I started to work with cannabinoids and do cannabis research. And I changed my lab to a name, Laboratory of Cancer Biology and Cannabinoid Research. Okay, but I'm really, really green in the field, and we're really starting to do work. I'm not like people here that are very well established. So when we are talking about cancer, we saw now 2 kinds of cancer. But cancer, it's actually, it's from the NIH. Cancer is the same, it's the name given to a collection of related disease. Okay? When we are saying cancer, people are coming to me and said, are you going to cure cancer? I said, if I'm going to cure 1/3 of one kind of cancer, I will get a Nobel probably, okay? When we're talking about cancer, we're talking about hundreds of different diseases, okay? So this is just a small list of cancer types. Every cell of our body, every different cell are different creature. When we're talking about tumor cancer, a brain cancer, and a skin cancer, it's a different disease with the same phenomena, but it's a different disease. So when we are saying that cannabis can fight cancer, which cells we are aiming for? Is it all cancer cells? Is it just one of them? Is it 2, 3? We don't know. So Cristina explained about apoptosis, and I don't know if it's going to work. No, it's not working. So anyway, I want to show you apoptosis. Apoptosis is a controlled cell death, that the cell like committing suicide. So when we are using chemotherapy, usually we're causing the cell to commit suicide, to kill himself. One of the reasons that cancer cells are proliferate faster and getting crazy, they know how to escape from this apoptosis, for this committing suicide. Normal cell, when he understands that he have kind of mistake and he out of control, he will kill himself, okay? Cancer cells know how to escape, okay? So this is the phenomenon that's called apoptosis. But it's very complicated. I want to skip it. It's very complicated. This is the basic apoptosis, but when we're talking about apoptosis, this is just part of the pathways that can happen in the cell. So when we are saying that it's killing the cell, what is the really pathway, how it's work? Is it the same on all cancer? We just don't know. Okay? And when we're talking about cannabinoids, Cristina just showed two kinds, THC and CBD, but we are treating people in Israel, correct me if I'm wrong, something like 10,000 people, right? We are not treating now with a THC or CBD pure. We are treating with the whole cell lysates of the cannabis. It's not just THC and CBD. There is another 400 component there. So which component is really important? We know that it's worked synergistically, and we don't know what's going on there. So what I am doing in my lab now, and we are really, really initiating the project now. We have this machine, and this machine, it's doing high throughput screening and scanning. It's like in an incubator that the cells can live there and be happy, okay? Cells from a human being need 37 degrees incubator. They need CO2, O2. They need things to maintain their life. Otherwise, they will die. So this is an incubator with a camera inside that can take more than 1,000 images per hour with very high quality. And the nice thing that the camera can move between cells or between places in the plate and take different images. So I can take a plate that have 396 wells, and in every different well to grow different kind of cancer or to do different treatment. And this camera knows to move between these wells, to take images, and to give me later, because it's combined to very powerful computer, to give me parameters about how many cells in this well had apoptosis, how many cells stopped proliferate, how many cells moved from one place to another or did invasion, like how many cells are aggressive. And from this parameter we can scan. This is one of the images, and this is in higher quality. You see here, this is the nucleus and this is the microtubules. Doesn't matter what it is, but that's the image that I'm looking for. This is without treatment and this is with treatment. And you see every yellow cell here, it's cells that overcoming apoptosis, that cells are dying. So I can treat with variety of treatments and see what is going on there. So, oops, why it's like that? Just a moment. Okay. So, what we are doing, we are growing a variety of cancer cells, over the 200 different cell lines that coming from biopsy, from people, different kind of cancer, and we're treating them with different kind of oils from different strains. And we're doing like a map. Okay, we're saying this strain is killing this kind of cancer, and this strain is stopping the proliferation for this kind of cancer. First, we want to have like a big map to understand how many kinds of cancer are influenced from cannabis oil and which kind of cannabis oil. With high CBD, with low THC, with different kind. Then what we are doing, we're doing fractionation of the oil that works. If we know that U87 glioblastoma cells are dying over apoptosis from this kind of strain, we're taking the oil and we're doing fractionation of the oil. And then we take these fractions and we started to put them on the cells, and we want to see which fraction actually is causing the cells to die. And then we're going narrowing and narrowing down to see actually which components are important, and what we know for initial work that we don't need just one component, and it's not just the THC and CBD. There are also some terpenes, and there are also some other cannabinoids that are very important for the synergic effect that we see on the cells that are dying. But this is really, really initial. So after that, just to show you the tools that we have to see what is downstream, what is causing to the cells to die, we have a variety of mice that have knockout genes. They have like genes that we can stop them to be. The protein is eliminated in the pathways of the apoptosis, and it's mice. We can activate these proteins. We can shut down the proteins wherever we want. If we want to look on skin cancer, we can do it just on the skin. If we want to see a lung cancer, we can activate it just in the lung. And then we can digest the pathway. We can understand which pathway is causing downstream to the cannabinoids to really to kill the cells. We called it the confetti mice because they are expressing different kind of chloroform, different kind of colors, fluorescent colors, and I don't want to get into the science, but what we can see in the end, it's really colorful. This is a skin carcinoma, and we see here the hairs. You can see here follicles of the hairs, and this is the primary cells, but this is the tools that we have to dissect this. So I spoke in the last 3 days with few physicians here, and most of them said, I don't care. If it works, it works. I don't care what is the pathways. And we are the scientists, and I'm sure that Cristina will agree with me. We think that knowledge is power. Okay? If we know what is the pathways that killing the cells, we will know better which chemotherapy to use with the cannabinoids, which is helping and which is interfering. Because the pathway, we're using chemotherapy to kill the cells through the same pathway. We don't want the cannabinoids to interfere. We want them to have a synergic effect with the chemotherapy to help them to kill the cells. So this is one reason why it's very important. Second reason, we know in the last few years that the way that the cell commits suicide, the way that apoptosis causes, influence the other cells. There are pathways that the cells are dying, that they are secrete materials to the other cells surrounding them to proliferate faster, okay? Or they can secrete materials to the other cells surrounding them to commit suicide too. And we want to be on this side of effect. We don't want to treat tumors that will shrink in the beginning and then start to proliferate faster, and we just see the tumor growing faster. So we know this phenomenon that we're treating patients, the tumor started to disappear, then it's growing more aggressive. And this is one of the reasons. So we want to know what are the pathways and what's going on there. And
okay, please.
Yeah, I'm done. And I think our the way that I'm selling it, let's say it like that, because as a scientist, I don't believe it's so easy to reach there. But the way that we think that we will be in the future, we call it personal medicine. So we will be able to take the biopsy from the person, to growing in the plate, to check very fast with the machine that I showed you, other machines, which cannabinoids, which is the really combinations of cannabinoids or whatever is killing the cells in the best way, and then to know how to treat the person specifically. Thank you very much.
Thank you. Now, except for the last lecture, all time was done, very good. And we will start the discussion to the presentation of Dr. Hazekamp. Do you have any questions to the first lecture? Yes, please.
In your presentation, and with the model in Netherlands, The only form available is weed, or pellets of crushed weed. But in fact, as we know now, there is more and more different forms used, including a lot of concentrates and a lot of way of using concentrates, from heating it to vaporize it or even dabbing it. And it looks like even in legal system, it's difficult to change the form. So are you doing something to study more these new forms and maybe to make other forms of cannabinoids for inhalation, because you establish that inhalation is the best route? Is it possible to have new forms or other forms than weed? Because it's a little bit strange to have weed and do our own concentrate at home. And for example, with gas, it's not so safe.
That's a good question. So let me repeat it. The question is if there are any administration forms being produced within the national system, for example, in the Netherlands, I think, right? But the thing is that when you provide medicinal cannabis to patients, that's one step. If you produce something out of that, then you're making a pharmaceutical preparation. And there's a whole bunch of laws that make things very, very difficult. But nonetheless, it's important to do research on that. And I have done research on vaporizing. I have a publication on Simpson oil, on cannabis tea. So what we can do as a scientist is look at what's happening in the real world, what are patients doing, and try to find out, is that safe, is that smart, what are the different options, can we compare them? That's available, oh yeah. And in the Netherlands we're now working on trying to prepare a cannabis oil that is reproducible and also quality controlled. So yes, we're following those trends, but to produce it, yeah, then you're almost like a pharmaceutical company, and that's not so easy. But we can study what people are doing in the real world. And so this is what I'm trying to say, huh? We should try to join this kind of information. I wanted to also add that if anybody wants to have my presentation, I can send it to you as a PDF. So just let me know.
Okay.
I have no question, but regarding the presentations, they will be on the website, all of them during all 4 days. And we hope to, since we are recording all the speakers, so we want to have it like interactive, so there will be the sound, I mean the whole voiceover and the presentation going on.
Thank you very much for this comment. Another question for Dr. Hazekamp? No. So, yes.
What for do you think is the best for drugs? I think the best is vaporize. And this is my son, and we was in Chicago, and one doctor wanna make him rhizotomy, but he have problem with spastic, and I know when I was young and I was smoking, he was 1 year old. It was first time, and we stand up technique. But I was young, and it was hypocrisy. No, heresy. It was heretic, and I don't give them. But now he's older, and when I have 3 sons, and I see what is going on in this world, and when I was in USA, and they talking about, and they have marijuana, but medical, that I wanna take first something natural for my child, and not make operation, not chemie, because this is my child. And when I go to Prague, to Berlin, and I see on the street they give them shit with chemie, and when I smoke without tobacco, only green, and I see what I smoke, that I'm angry, and that's why this is my question. Why? Because I'm from Poland, and we can have nothing, and I can help him, but when I have information, then I have one doctor in Poland. He's neurology doctor, and he said me, when I know what is going on and how many and what should I give them, then so can make this in Poland.
Are you asking me what is the best way to use cannabis? Well, the last speaker already gave some indication. If you say cannabis cures cancer, then the question is, what cannabis? How do you use it? What kind of cancer are you trying to address? There's not one single answer to that, I think. I think what we see from the data is that a lot of people prefer inhalation, but that's before cannabis oils became popular. So maybe it's totally different right now. I think the role of the scientific community... No, that was just an example, but there is no clear answer to that. There's so many diseases and so many different kinds of cannabis, so I think we have to find the best combinations. If you go into a pharmacy, you will find 100 different painkillers with aspirin, with paracetamol. You cannot say this is the best one. No, they're the best one for different groups of patients. So we just basically have to study in the lab what we can understand, and we definitely have to talk with patients and see what they do and what we can learn from that.
Thank you, but you can discuss with the other people here, I hope. So the questions for Professor Cristina Sanchéz, 2 questions only. So this was the first and the second.
Thank you. I saw the dosages you used in the mice studies were 45 milligrams per kilogram. Those are rather high dosages. The normal dosages are like 5 to 10 to maybe 20. Was there no effect on the lower dosages? And the second quick question was, can you explain the mechanism of CBD, since it doesn't work through CB2? So can you elaborate maybe perhaps quickly?
Okay. Regarding dosing in the animal experiments, the doses we use may sound very high, but you have to keep in mind that we are talking about different animal species. So the human metabolism and the murine, apologies, and mouse and rat metabolism are completely different.
No, but in the mouse models as well, they generally use like 5 to 10, maybe 20 as
Yeah, in some of the experiments I have shown you, we used as low as 5 milligrams per kilo, and we saw an effect. And we see an effect when we combine the best effects. We find them when we combine low doses of THC with high doses of CBD. So that's one of the things we are doing now. We are trying to find out what works best for each type of tumor. So I wouldn't say THC, I wouldn't say CBD, I would say it depends on the tumor. And I agree, we have to go through personalized medicine. And one of the things we have to personalize is the type of combination we have to use for each patient, depending on his pathology and what works best for him or her. And the second question, there was a second question regarding CBD mechanism of action. That's...
This morning lecture was here.
Yeah, specifically for breast cancer, which is what I'm studying right now. We know that there is a production of reactive oxygen stress, but we have seen also implication of the CB2 receptor. I know that this is not, in some cases it has been reported that there is some involvement of this receptor in CBD action, and in breast cancer it seems to be one of the main targets. But we are working on that as well. Yeah. Thank you.
Okay, second question was here.
The question is, y espero poder hablar con usted un poquito más tarde, pero the question is, you mentioned THC and CBD, you use THC and CBD in your studies. Is it natural or synthetic?
We used both. We used in some cases, especially at the beginning of our studies, we used combination of pure compounds, and more recently we are using botanical extracts. Both.
Okay, so one question for the assistant professor Meiri. Yes, one question here. No, it was the first, that one.
Hello, thank you. Just a quick question to all of you. It's not a scientific question, I'm sorry, I'm not scientific, but in order to help the research, we need money. And I know that in Spain it's quite difficult to find money because of financial, and I would like to know, to raise this result that seems to be the first one and the best one, and how much money do we need to prove or to find a way to defeat cancer?
It's very simple. It's clear cut. As much as you can arrange. If I will have 500,000, I will put 10 students. If I will have 1 million, I will put 20 students, and it will be faster. It's always a matter of money.
But if we want to go faster, maybe if we let the people the right to choose their plants, maybe we can have this private medicine.
I want to add something to that. We're not involved in any of the 2 clinical trials I have shown you in the slides in my presentation, but Guillermo Velasco is involved in the design of a new clinical trial in Spain, and they have designed the protocol. They have already talked to the doctors, and the amount of money we are talking about is $250,000 euros. Sorry. So that's what a standard and small, a very small clinical trial costs. So I don't know in the rest of Europe, but in Spain, that amount of money, it cannot come from public sources. So we depend on other sources. I don't know if you know the cannabis cannabis bike tour. They gave us some money to do the trial, but still it's not enough. So I'm afraid we depend on the pharmaceutical companies.
But this is the eternal questions, you know, and this is not the direct connections between the money and the discovery. No, it's completely different. It's very complicated. We can discuss it for every time. So my thanks are going to all speakers and also to all of you. You are resting here. And the next, last sessions will start, I think, in 15 minutes, yes? Okay.